The treatment of multiple myeloma is continuing to revolutioning in last years, and particularly frontline setting has seen many novelties, starting from the introduction of isatuximab, new generation anti-CD38 monoclonal antibody that has become a new potential backbone, starting from elderly transplant-ineligible patients in which isatuximab added to VRD, bortezomib, lenalidomide, dexamethasone, is giving incredible results in terms of deepness of response, in terms of quality response, quality of life, and I think the TIMROT's combination, according to the exciting data about MRD negativity and sustained MRD negativity, can become the standard of care in this category of patient. In transplant eligible, we have daratumumab VRD that, according to Perseus EMN 17 clinical trial, has become the new standard of care, now reimbursed also in my country, in Italy, and the results are incredible. And I think that the idea of a projection of PFS till 17 years in a median, I think that can take the patient to think to myeloma in a really different way. Let's not forget that we have also GMMG HD7 with the isatuximab VRD that is not reimbursed in this moment, but can be another potential standard of care, also according to MRD negativity data and in the idea of deepness of response for transplant eligible patients. Some patients that are not able to come often in the hospital, DARA, lenalidomide, dexamethasone continues to be a potential standard of care. And let's not forget that many clinical trials are going in this setting. We have to see the positioning of bispecific antibodies, CAR-T, according to the trial that are ongoing, and also belantamab mafodotin, according to DREAM9 and the ongoing DREAM10, can find a place in frontline treatment. So I think that we will have new revolutions in the upcoming years. In terms of relapsed refractory multiple myeloma, we know that in this moment, starting from early phase, early relapses, we have incredible amount of exciting combinations, starting from teclistamab and daratumumab, as we have seen at last ASH. This is an incredible combination with exciting data, and I think probably together with the CAR-T cilta-cel that have been now reimbursed also in my country according to CAR-T2D4, these are the standards of care in patients that are in some way young, fit, and have the condition to reach a very good and sustained in the time result. Let's not forget that we have other combinations for people that are naive for anti-CD38 monoclonal antibody. Isatuximab, carfilzomib, dexamethasone remains the standard of care, and is also a wonderful bridge for patients that are waiting for CAR-T, for cilta-cel. Let's consider that we have also belantamab mafodotin with the incredible data coming from DREAM7 and DREAM8 in combination respectively with bortezomib, with pomalidomide. This is an antibody drug conjugate. The results are incredible, and tolerability in earlier lines with the lower dose is absolutely more than acceptable. So I think this is another potential standard of care, also in patients that are coming from a frontline daratumumab based, but also in patients that are dara naive if they relapse during, for example, lenalidomide maintenance. Maintenance is also something in which we have to consider that in this moment we have only lenalidomide, but according to Perseus we will have dara lenalidomide, and there are ongoing the results of the trials with the bispecific, for example, elranatamab and teclistamab in maintenance. So also in this case we will go to potentiate the maintenance approach. In later relapse, we have many data with new drugs, new combinations, and I think that we have to consider that cilta-cel in fourth line, according to CAR-T2D1, 33% at 5 years of PFS can be something that can really change the lives of our patients. Let's consider that we have also monotherapy with elranatamab or teclistamab that are also really effective, well tolerated. Data of deep response are also quite exciting, and we have to decide who is the right patient for every drug. In my idea, we have to think better in terms of sequencing, and we have to consider that probably also an anti-BCMA based sequencing can be something that could be effective. We have some data from international institutions that collected the real world, antibody-drug conjugate belantamab fodotin, bispecific antibodies elra, teclistamab, and then linvoseltamab, etentamig, and in some way CAR-T, cilta-cel and ide-cel are not the same drug. So the idea of sequencing them to offer the best to our patient is something that we have to better investigate. In other relapsed patients, let's not forget selinexor, XPO1 inhibitor, that we can use in combination with bortezomib and dexamethasone, with a quite good tolerability if prophylaxis for gastroenteric tract is done very well, and we do netupitant and palonosetron as prophylaxis, and we are really well with our patients. And let's not forget melflufen, a new way of intending chemotherapy, really selected, really personalized, with a very good tolerability and a fantastic schedule, because with one infusion every 4 weeks, patient can have a new treatment, another mechanism of action, and in some way this can be considered also as a bridge for cellular therapies, or also in some way as a therapy in which we want to change mechanism of action, for example, between anti-BCMA bispecific antibodies and talquetamab, and something like that. In our real world, we are also collecting data and in some way analyzing them. Melflufen is something that is giving in our daily practice data that are also improving the ones of registrative trials. So let's not forget this drug. And I think that other combinations are arriving. We are going with a lot of phase 1 clinical trials. We have to discover how is the life after CAR-T, or in terms of refractoriness to CAR-T. So I think the best has to come, and I think that the novelties will be available as soon as possible, and the cure of multiple myeloma is not far anymore, and this is the best wish that we give to our patients, to their caregiver, and to all myeloma researchers.